So I will just share my PPT. And once again, sorry, it's already 10 minutes late. And as Shiba said, don't know, I'm not so well versed with the palliative. I'm also still learning only many things, especially from others. Whenever I hear a new topic and same topic, sometimes I will learn something very new also. Okay, so welcome to all. And today our topic is pain management. I'll just share the screen. Hmm? Mm, how to the pain is emotion, pain is a signal, it is an unpleasant perception, Kiran's unpleasant feeling, cause distress, unpleasant experience. Very good, very good. So you all know pain. So I think I need not take a session for you. Can you make this one in physical distress? Okay. So let us see about what is pain. Uh, next slide, please. Next slide. Okay. So, our learning objectives for today is identify the barriers to educate pain relief in seriously illness for patients across the lifespan. I'm not talking about all the serious patient, but for any patient, we need to know the barriers also which is a barrier for a pain relief. Okay, and a thorough assessment, pain assessment. We should know how to assess a pain. Then, of course, these pharmacological and non-pharmacological therapies will come in your next sessions. But you have to know about not only pharmacology but non-pharmacological also, because many of our palliative patients will be at home. So we need to tell them about non-pharmacological therapies also. And of course, the role of the nurse involved with pain assessment and the management. So, first and foremost is how to assess a pain is very important for the nurses. Next slide, please. So, the guidelines, when we say you should have an understanding of the patient's goals, like physical, their functional, emotional, spiritual, social. So when we talk, it should come to, so some goals should be there. We need to know, find out what are the goals of the patient. We should focus on relieving the symptoms and improving or maintaining their functional status and quality of life. I cannot say that all the pain we can remove, like, okay, we can reduce the pain so that the patient's functional daily functions can be improved and the quality of life can be improved. Then, of course, as I said, pharmacological, non pharmacological intervention, behavior, so many other complementary therapies also are there. We like to know about that. And of course, the symptom management across all care settings are accomplished through communication. So, very important is communication. I think communication is already been, they must have done for you that session. So, communication is very important because without communication, you cannot assess the patient. Collaboration in the sense of collaboration and coordination between all the professionals, that is also very important. Just as a nurse, you cannot do anything. Okay, so you need to assess and then discuss with the doctors or tell them so that they can prescribe what the patient needs, and then we have to intervene into that and implement it. So, and the coordination, why we need a collaboration coordination is when you are working with a team, they would like to know what is happening with the patients. Okay, so next slide, please. So, what is pain? So many of you have written this an unpleasant perception, unpleasant experience, very right. So you have defined it in a very nice way, and now we have to describe it also. Okay. So just defining it is not important, is not the only the thing, but we have to need to describe it also. Okay. So description, who will give? The patients are the ones who are going to give describe what is the pain exactly, how they are feeling about it. Okay, so next slide, please. So, pain, an unpleasant sensory and emotional experience associated with or resembling with associated with actual or potential tissue damage. It can be or not be. But exactly what it is, when what the person says it is hurting, that is called pain. If I have a small cut over here, and if I say it is paining for me, it means it is paining for me because I am perceiving it. After a surgery, major surgery of abdominal surgery, maybe the patient can tolerate that pain, may not complain of pain. But a small cut in your finger, you will be going on complaining of pain. So that doesn't mean the patient doesn't have pain. The small cut can also cause pain because how it is your tolerance power. Okay. So when a patient says it is paining or it is hurting, it means the patient is in pain. Okay. Next slide, please. So pain, keep always in mind that it's a subjective experience and it differs between persons. That's what I said. A primary patient may not shout in the labor room, but a multigravida patient may be shouting in the room because of pain. So that doesn't mean primary why if the primary patient is not having not uh, what to say not feeling, I should say, the patient is able to tolerate that pain. Maybe a multigravida she cannot tolerate that pain, but still the patient is having the pain. So it differs between the persons. Okay. And it differs with time and situation, even in the same person. Some people may say, after taking food, I am having abdominal pain. Some others say, after taking, before taking only, I am having pain. But after taking the food, it's fine. So, like in ulcers, many of them, they have, when they have these abdominal uh, problems, abdominal ulcers, many of the patients, they say, after taking food, I feel fine. Okay. So, it differences in time also, it is the time and the situation. So an unpleasant sensory emotional experience, we said, and of course Robert Ty Cruz has said patient is pain is what the patient says it hurts. So I hope it is clear to you all. So next slide, please. 80% of the patients with advanced cancers has moderate to severe pain. We need to admit it. And to pain management, why? Fear of pain may mean disease progression and recurrence. Many of the people are scared to say that they are having pain because they have that fear. If I say the pain is increased, it means my disease has progressed. Or maybe I am feeling weak. People will think that I am very weak, I cannot tolerate pain. That's when I am talking about pain. Not wanting to distract their provider, because if I have heard a patient's family saying, because he is always in pain, we are not able to do our work, not able to attend on anything. And the next is not wishing to appear to be a drug seeking, because if I say pain, whenever I tell pain, I need to take medications. So what the people will think about me, they will say, oh, he's a drug seeker. So again, they will try to tolerate pain. Patients may believe anything, that everything is by being done for their pain. And that is also one fact. What they think, so many medications I have taken, still my pain is not reduced. Okay, so now there is no medications for that. So this is the ultimate thing what happens. Next slide, please. So some factors. factors that affecting the pain perception. uh, when pain increases due to many other things, as I said, fear, our anxiety, discomfort, even sleeplessness, and of course lack of understanding about the disease. Many of our patients don't sleep in the night because they are scared, and this in itself can increase their pain. But pain can is reduced also in many things when there is an acceptance of the disease progression, when the patient is feeling happy, good sleep, and good companionship. If there is a people to support the patient won't will also feel that his pain is decreased. Next slide, please. So, pain, there is an acute pain and a chronic pain. Acute pain present at the site of the injury, and chronic pain usually it is related to pain in conditions like diabetes, arthritis, and tumor growths. Next slide, please. So, and chronic pain is defined as a persistent, recurrent pain lasting more than 3 months. That is chronic pain, and this chronic pain usually it affects the quality of the patient's life. It affects the mood of the patient. When I'm in pain, I won't like to talk to anyone. I will get angry, I will lose my temper, I may not eat. Okay. And who suffers? The family also suffers when the patient is in pain. So this is very important. Chronic pain, we need to, how we attend to acute pain, in the same way we need to attend to the chronic pain also. We need to manage chronic pain. Next slide, please. So the concept of total pain was introduced by Dame Cicely Saunders. What Dame Cicely Saunders said was, pain is not only a physical experience. When we talk about a total pain, physical, psychological, social, and spiritual. This is total pain. This all contributes to the pain. Psychological, if you keep aside the physical, psychological, social, and spiritual also contributors to the pain. So when we assess pain, we need to see that the total concept of the pain, not only the physical, the other related associated things also we need to address. So when we talk about types of pain, one is nociceptive pain and another one is neuropathic pain. Nociceptive pain usually the it is resulting from the injury of the tissues. Okay, and it's stimulation of the peripheral nerve endings. Like when a patient is having a cancer wound, the patient will feel very painful. The wound will be because all the nerve endings are stimulated or it is open, uh, exposed. Okay. The second one is somatic pain, usually generated by the deep tissues like bone and soft tissue. That is also a nociceptive pain. And the another one is a visceral pain. Visceral pain is the pain usually due to the capsular. This one, what we talk is liver pain, bowel, cardiac pain, and all will come under visceral pain. Okay, so the nociceptive pain are somatic pain, and we can see the visceral pain. Now, next is the neuropathic pain. Next slide, please. Neuropathic pain is usually the resulting of an injury to the nerve. So that is neuropathic pain. Usually in neuropathic pain, the patients will explain to you how their pain is, like burning sensation, pricking, needle prick type pain, stabbing pain. These are the things what the patients will explain to you. When you, especially when you take a wound, patient will tell it is like a pricking or burning sensation. Oh, okay, peripheral vascular disease patient. Okay, the smokers, when they have an ulcer, usually what's it's burning like anything. Otherwise, pricking like type burn pain. Okay, so that is neuropathic pain. So in neuropathic pain, you can see allodynia, hyperalgesia, and referred pain. So, what is allodynia? Is a pain resulting from a harmless stimulus. And hyperalgesia, exaggerated response to normal stimulus. So, like recently, if there is a burnt area of a skin, okay, and when I touch, the touching itself will cause a pain. That is hyperalgesia. Okay. And when we talk about allodynia, usually what doesn't give pain, but I will feel pain. So these are the referred pain is pain felt in an area other than the site of the virgin. Okay. So these are the other three types of the pain. Okay. Now assessment of pain. How we are going to assess pain? So as a nurse, when we assess a pain, we need to be with the patient. As far as possible, please ask the patient itself about the pain, not with the bystanders. If the patient is able to communicate to you, if you are able to understand the language of the patient, better you need to communicate with the patient. So it needs a very good skill also how to assess the pain of the patient. Plus, you need to have a good listening and good observation power. When assessment is incomplete, the management will be inadequate in the pain control. So, assessing pain is very important. Next slide, please. So, for when performing an assessment, first and foremost thing is you should have a good relationship, otherwise rapport we say, with the patient. Addressing the immediate need of the patient is very important, especially when the patient is having severe pain. Don't keep on asking the history to the patient. Immediately what we have to do is find out the pain, and then we have to treat the patient first. In severe pain, please don't sit and take the history of the pain, because in history we need to take a lot of things, but when in severe pain it's very difficult, because we have to first reduce the pain. Second thing, active listening. Whatever the patient is talking to you, we need to listen to that. Do have an empathy touch. Don't be judgmental. And of course, starting with the open questions like when the pain, onset of the pain, when the pain started, how is that pain, how the pain is, what is the impacting the life of the patient. So many things are there. Okay, so you can start off with that. And of course, encourage the patient to talk. If you are listening properly, you can encourage the patient to talk. And of course, look for verbal and non-verbal cues while performing the assessment. And at last, please summarize whatever the patient has told pain, about the pain and its problems. Okay, next slide, please. So, usually what we say is, apart from this, I will just talk to you. First and foremost thing is onset. O we say. O, onset. When the pain started. And before that pain started, before that onset, how was the pain? Suppose I say, my pain started yesterday. Since yesterday, I am having pain. Before that, before that, I had very mild pain. But now I am having, since yesterday, I am having severe pain. So onset is, since yesterday, I am having severe pain. That is onset. Okay. Then comes, what is the P? P. Provoking and palliating. What provokes my pain? Like some patients will tell, when I get up and walk, my pain increases. What is palliating? When I am at rest, I don't find pain. My pain is reduced. So, what provokes the pain, we have to find out. So, we need to ask the patient, when is your pain increasing? Or when is the pain decreasing? So, O, P, next is Q, quality of the pain. What is Q, quality? Quality means how the patient is going to describe to you about his pain, whether it is burning sensation, whether it is needle pricks, stabbing, throbbing pain, colicky pain. So these are the quality of the pain. And this is very important. When you talk to a patient, it is very important. The quality of the pain is very important, because from there we will come to know whether this is nociceptive pain or it is neuropathy pain, because different medications we have to give according to the quality of the pain. Okay, now after asking that, next comes the R. R means region, otherwise site, and of course radiating also. Like you can ask the patient, where is your, can you just point out and tell me where is your pain? So the patient says, my pain is here on the shoulder. So is the pain only on the shoulder or it radiates to your hand? Like cardiac pain, it radiates also, right? The pain comes from here and it radiates to the hand. Okay. So if the patient says, no, the pain is only in this side, well and good. Suppose the patient says it is radiating to my hand, like renal colic. Pain starts from the back and it radiates towards the front. Some patients, when they say I'm having backache and it radiates down to my leg. So we need to find out about that radiating pain, the site of the pain, and especially in cancer patients, we do see that there will be different types of many sites where the patient may have pain. So find out from the pain patient about the pain and the quality. Some days what they say, like the hip pain, okay, backache. I'm having severe pain at the back, which is radiating to my leg, and I feel numb. There is numbness also, and burning sensation under my feet. See, different types of pain. So we need to ask about the, so O P Q R S. Now S is severity, whether it is mild, moderate, or severe. For that we have scales. I will come to that. So just ask the patient otherwise also, how is your pain? Can you just explain to me how is your pain? Whether it is mild pain, moderate, or severe. Some patients can explain about it. So ST. Now T comes temporal factors, treatment, everything comes. Like, are you taking any medications for your pain? The patient may say, yes, I'm taking medication, but I'm not having pain relief. Is the pain same like before? So like some patients, they will tell, last time when I came, my pain was severe, but now the severity is reduced, but still it is continuing, but there is pain. One thing, some may say, yeah, I'm taking medications 3 times a day. If suppose I'm taking at 8 o'clock and the next medication is somewhere around 2 o'clock, in between by 11 o'clock my pain comes back. So, according to the medication, also we need to ask the patient how the patient's pain is. Treatment related pain is also there, like patients' radiation. After taking radiation, they have that burning sensation. That's also pain. Just for a small example, I can tell you, when we remove our tooth, okay, tooth extraction is done, okay. Sometimes before the tooth extraction, it is not much painful, but after taking it, we will have pain also. So treatment related pain, like surgery. After surgery, we will have pain because it is treatment related pain. Okay. So ask the patient whether any treatment related, like after radiation, you are having pain, pain is increased. We have to find out. Second, whenever the patient is taking medication, with the medication, whether the pain has reduced or the pain is still the same, continuing, or the pain is increased. What medication the patient is taking and the timing of the medication is very important. Whether we have written for 8th hourly, 6th hourly, otherwise 4th hourly, whether the patient is taking the medication at the right time, that is very important. because if the patient is not taking the medication at the right time, patient will have pain. So we need to find out that also. That is the treatment related or anything. Okay. The last thing is, what is the impact of that pain on the patient's and the family life? That is I. So OPQRSTI. I is impact. For example, I told you I am in severe pain, and because of my pain, my family is not able to sleep. The family is not able to do any work. Due to pain, I am not able to go to the washroom. I am not able to sleep. Due to my pain, my family is also disturbed. So the impact, because that is a distress for me when I see that I am in pain, and of course my family is also suffering from that what I am suffering, and they are not able to do their routine work. So that time what will happen, I will feel distressed. So these all things we need to find out from the patient. This is how we are going to assess the pain. And if you assess a pain properly, then we can give a proper medication, or there is proper treatment. Okay, so that is what here it is written: the site of the pain, frequency, whether it is continue or intermittent, how long does it last, we need to find out. How is the patient's activity of daily living, their sleep history, medication history, and what is the route the patient is taking, whether the patient is oral medication, otherwise subcutaneous or IV, whatever it is, the route of the medication what the patient is taking and how often. So this is very important, how the patient is giving you the history of the pain. But you people also need to know what you need to ask the patient. Next slide, please. So that is here, PQRST. This is what I was just explaining to you. So now assessing, when we are assessing the severity of pain, self-report of the pain is the best report, as I told you. Let the patient report to you. Suppose if the proxy is reporting to you, you need to teach the proxy what all questions they need to ask the patient and then report to you. Whether the patient is having pain after medication, if you ask, they will tell, "Hmm, no, maybe," because they have not asked the patient properly these questions. They are not sure about it because they did not talk to the patient. They just came to collect the medication, or come just came to report to you that patient is having pain. So proxy people, any patients bystanders are coming, teach them how to take a pain history from a patient, so that when they come to you, it will be very clear. Second thing is, no one can exactly grade the intensity of the pain that patient is experiencing. Pain scales are there, numerical scales are there, VAS scales are there. Wong Becker's face pain rating scale is for the children is there. So many types of scales are there. Next slide, please. Now you can see this one, 0 to 10. Some days only it will be 0 to and the worst pain, no pain, and the last one will be 10, the worst pain imaginable. Ask the patient, see, if 0 none pain, 1 to 3 is mild, 4 to 6 is moderate, 7 to 10 is severe pain. So you can just ask the patient, where is your pain? Otherwise, if you don't have a scale, you can ask verbally to the patient, how is your pain? Is it very severe that you cannot tolerate? Is it just little pain coming and going, like a mild pain? Some patient will tell, yeah, pain is there, but it's okay for me. It's a mild pain. Now, moderate pain, when the patient says, yeah, pain comes and goes. Sometimes I'm not able to do some of my work. But when it comes to severe, patient will say, I'm not able to do anything. Patient may be screaming. So it means the patient is in a severe pain. Some Previously they used to show the coins. Okay, 25 paisa or 50 paisa something. How much is yours? Okay, but this also can will help you to find out whether the patient is having mild, moderate, or severe pain. Next slide, please. This is the womb maker's pain. We have to see the faces and ask the child. If the child is able to talk, you can ask the child which is the face of the what the child is, what to say. Ask the child itself, out of this face, which is the child's face. Otherwise, you can just have a look at that and find out what is the change in the child's face. How the child is having the, how much is the child having the pain. One more thing we have to keep in this one, many times it happens due to fear of injections and other things. Sometimes the children will never tell about their pain. Mothers can explain better because they know, they may tell you, if my child is not in pain, even if it's little pain also, the child will be talking, otherwise doing something. But now the child is in severe pain, that is why the patient is held, the child is held holding me tightly, otherwise crying so severely. Okay, talking to the family member, especially mother, it is very important. This mother is a person who is with the child, always. So mothers can explain to you about the child's pain. Next slide, please. This is a pain assessment chart. Many places they use it. Wherever there is pain, one is the front side, other one is the back side. Wherever there is pain, you have to mark it or shade it, and to show that the patient, where the patient is having the pain, both, maybe in the front or in the back. And then you can just write and keep the type of pain what the patient is having, the quality of pain. Next slide, please. So, what are the barriers to pain relief? Specific barriers are, one of us, we itself professionals, because when patient says paining, we'll say, oh yeah, it is okay, because since you have undergone a surgery, you will have pain. It's because of cancer you are having pain. Because of your wound, you are having pain. Okay. The second thing is healthcare system, that is due to the medication is not properly available. Many of the medical, like when we talk about opioids, of course now opioids are available in many of the states, which reduces the pain very nicely, but all the medications are not available. Very less medications are available in the government sectors, otherwise the patient has to pay and buy it. So again, that is a big problem. Next comes the patient and the families itself. Patient feels that if I say that I'm having pain, it means that I'm drug seeking. Otherwise, the fear that my disease is progressing. And families are another, not only families are the another problem. They will tell, just now when you have taken a medication just 2 hours before, now you're still complaining about pain. Again, how we can give you medication. Even if it's say, tell to the family member, SOS medication should be given. Whenever the patient is having pain, you give the medication, still they won't give, because already you have taken a medication, no need of taking more medication. And especially they have a phobia over the opioids, so especially morphine and all. When they say morphine means it is a drug, it should not be used so much. So these are the barriers to the pain relief. Next slide, please. So, strategies to overcome the challenges in pain management. First and foremost, education of the healthcare professionals. All the healthcare professionals should know how to assess a pain. Assessment is very important. After assessing, reporting is very important. Then comes the intervention, what we have to do, and intervention, implementing that intervention. Then we need to do the follow up. So all these things are very important. Management, we have to use current guidelines. Proper analysis should be used for the pain management. Like for nociceptive pain, there is medications. Neuropathic pain, there are some other medications. So accordingly it has to be used. That I think you will have some sessions on that. Okay. Monitor outcomes, that is very important. You have given a medication to the patient at 2 o'clock. Just after 1 o'clock, just go and find out how is the pain. Teach a family member also how to take the history of pain. After giving medication, how the patient's pain has reduced or not. That is very important. And attend to any adverse effects also. If there are some adverse effects of the medication, that also had to be attended. Education of the patient and the families is very important. Set realistic goals because the patient needs to know what is happening with them. If the patient doesn't know, patient will go on complaining of pain and pain and pain. And also realistic goals has to be set up, and provide psychosocial support. That is very important. Psychosocial and spiritual support is very important. It's not only physical. If the patient is having psychological, as I said, if the patient is saying that at night I'm not able to sleep and is having pain, so it is not only the sleep pain, but why the patient is not able to sleep, it's not only because of pain. Patient may be in fear. One of the patients said, all are sleeping, so I am not sleeping in the night, because if something happens to me, these people won't come to know. They are scared of sleeping in the night. Maybe the patient is sitting and thinking a lot, and that is why he's not able to sleep. Maybe the position, how he's sleeping, that may be hurting and he's finding pain. So we need to give a comfortable position. So things are there which we need to find out from the patient and the family. And of course, lot of research has to be done for the pain assessment. Next slide, please. So goals of pain management, providing adequate pain and symptom control is very important. Decrease the distress caused by the patient in the by pain in the patient and family. So how we can decrease their distress? By reducing proper, giving proper management, we can reduce their distress. Provide an acceptable sense of control. Relieve caregiver burden, because see, if somebody is sick in my house, not only they are suffering, but I am also suffering. I will also be burdened. So we need to relieve their burden also. Strengthen the relationship between the patient and the family, maybe between the this one healthcare team and the patient and the family. Optimize the quality of life of the patient, and of course enhancing meaning of life and illness, providing personal growth. We need to talk to the patient and the family about their illness. Next slide, please. Patients at risk for undertreatment are children and older adults. They are under the risk because usually when children complain, they don't complain of pain because of the fear of giving injection. And of course, older adults also. Non-verbal, people who are not able to verbally, uh, what to say, express about their pain. Patients who deny pain, some if they have pain, sometimes you must have seen someone walking like this with pain, and if you ask if there is pain, they will say no. I'll tell for myself, when I undergone a cesarean, I was having pain. So they will give us pain medication. Okay, so I know they will give me injections, and I'm very scared of injection till today. Okay, so I tried to tolerate my pain, but I was feeling. So my friend, she came and I said, you are in pain? I said no. Then she said, no, you're having pain, I think. Why you are tolerating? I said, instead of don't give me the injection, you can give me some tablets I can take. Okay. So some are very scared. They can deny of the pain also. And who the people, I just put like that, any language problem. If I'm not able to express to you in your own language about my pain, it's very difficult. So sometimes that is also a problem. And some cultural things also there, where they say you should tolerate your pain, you should not express your pain. Like they say now, boys should what to say, boys should tolerate pain, boys should not cry of pain. Some things are there. Okay, so next slide please. So 80% of experience acute unrelieved post-operative pain. You can see assessment and treatment of pain is a basic human right. We all have the fundamental of right to be relieved of pain. 80% of the pain are unrelieved. Pain is unrelieved. 25% of the residents in nursing homes receive no intervention for pain relief. And unrelieved pain may lead to requests for medical aid in dying. I have seen patients due to pain, they say, please kill me. I don't want to live because of pain. So it is very important. Dementia, Alzheimer's patients, they cannot explain to you that they are having pain, but we need to observe them. Some things will be there which the family will tell that something is wrong because they must be in pain. Next slide please. So nurses, you will have some ethical classes also on ethics. So nurses uh, should know how to assess a pain because it's very important, because the patient is benefited in that. We should not harm them, and it is their right. It's a fundamental right to reduce their pain. We need to do have justice. We need to show justice to the patient and the family. Next slide please. I think this is the last one. So thank you all so much. We will go for the discussion.
Thank you, ma'am, for the wonderful session.
Sorry
Anybody have
Shiba,
any?
I don't know how much they understood. I was also in a hurry.
It was clear. It was clear. Uh, so, anybody have any doubts or any clarification need? Please ask. Anybody? So I think they don't have any questions. It was clear. So before moving on to the case presentation, I would like to highlight few things. So ma'am has explained very well about pain and introduction assessment of pain. So we should know pain is a subjective experience. Pain is what the patient says first. So we should, as nurse, we should believe the patient words. That is must. If someone says pain, we should believe the words, believe the patient words. That is, uh, we should keep it in mind all the time, because this is a subjective experience. They only know how much pain they feel. So we should ask how much pain they have. So we always you have to think about the total pain concept. And in nursing, we learned acute pain and chronic pain, but today you learned about few more pains: nociceptive pain, neuropathic pain, visceral pain, and yeah, so somatic pain and all. So these all things is very very important while we assess patient pain. So uh, if someone complaining of tissue related pain, that is related to nociceptive pain. If someone's that complaining of radiating pain, so something may be resulting injury to the nerves. So that is why the patient is complaining of radiating. The pain is radiating from one area to the another area. Maybe because of the tissue injury, sometimes the tumor will be compressing the nerves. That time also the patient may feel neuropathic pain and visceral pain. So again, if this pain may a patient may feel like stretching of capsular stretch, like liver capsule, that pleural effusion. If the patient is having pleural effusion because of the pleura expansion, that time the patient will feel pain. So that all things you have to keep it in mind. And also coming after this, assessment, that is that each step, each word is very very important. Ma'am has explained very well. Yes, DPQRST. When we assess pain, if you keep it these synonyms, SDPQRST, yes, you don't miss anything. Yes. What is S? Site of pain. D, duration. P, palliative factor or provocating factor. Q, quality. R, radiating. S, severity. T, temporal factors. So, how can we assess severity? What is quality? Quality is the type of pain. And severity, again, we have learned about many that types of pain scales, numerical pain rating scale, Wong-Baker Faces pain scale, visual analog scale. So if they can understand 0 to 10 scale, you can use the 0 to 10 pain numerical pain rating scale. So they can able to tell their that severity pain, the 0 to 10 scale. Okay, so that is also very very important. So always you have to keep it in mind. Okay, if you keep these things, if you keep it in mind while we assess the pain, you don't miss anything, you won't miss anything. So if you do the proper assessment, definitely based on your assessment you will plan. If your assessment is clear, your plan will be clear and the patients will get benefit. So that is about today's session. Anybody want to anything, any need any more clarification? Ma'am, do you want to anything add?
No, Shiva, what I was also, what you were telling is very right. Uh, More than, see, they need to know, you people need to know about the pharmacology also of the medications, especially their uses, and of course, the side effects of the medications. Okay. Little bit of side effects of the medication will help you to understand if the patient has taken some medication and the patient is having some side effect, we can manage that side effect also. That is one thing. Second thing is, in proper when you do an assessment, okay, be very clear with the patients. Whatever they are talking to you, try to understand what they are telling you, and if you have any questions, better ask the patient and clear out that questions. For example, I will tell one of my patient, I still remember, he came, peripheral vascular disease patient, and he said he's having pain on his leg. Okay, so I asked from where to where. So what, you know what he said? First he said, I am having a back from the back, my pain is radiating down from the back. Then he said it was like a, what to say, shooting pain, electric pain, it is traveling. Okay, then after that, when he said it has gone down, he said numbness is there and burning sensation. Okay, so when he said burning sensation, I too was thinking burning sensation is having, numbness is also having, and when there was an ulcer, okay, that with that ulcer he was feeling, again that ulcer also he was feeling burning sensation. So different types of pain, when they say, we need to write it, document also in that same way. Patient is saying from hip to the knee he is having this type of pain, and he is having burning sensation of the under the feet. So whatever the way the patient says, please put it in their own language about how they explain it to you. That is very important, so that the treating doctors can give them the correct medications to reduce their pain. And of course, you should have a very keen observation power also, to observe the patient from far, when you are on duty, to see after taking medications how the patient is, whether the patient is still in pain. You need to go and ask the patient also after taking medications, after giving medication after some time. It's not that 8 o'clock you have come to duty, you're given medications, 1 o'clock you are handing over and you're going. No, just in between, go and find out from the patient whether they are having pain or not.
Thank you, ma'am.
Yes, 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 you.
Okay, thank you. Can we move on to the case presentation?
Yeah, yeah, yeah.
So, Buddha Lokhar will be presenting a patient story today. Buddha, is over to you.
Good afternoon. Start the presentation.
Buddha, can you hear us?
Yes, ma'am.
Yeah, you can continue. You can start your presentation.
Okay, ma'am. Good afternoon, everyone. Today I'm going to present a case presentation on the topic chronic obstructive pulmonary disease (COPD) with pleural effusion right with dengue fever. Next slide. At present, the patient is admitted in our own hospital, that is Namchi District Hospital, and the present chief complaints of the patient is fever and chills since past 3 days, shortness of breath, body ache, wheezing, cough that is productive, and pain in the chest while coughing. History of illness. Patient had the symptoms of breathing difficulty and was admitted in hospital and was diagnosed with COPD since 2018. And patient got admitted and was treated for COPD in the year 2018. That time also patient was having shortness of breath, fatigue, decreased daily activity, cough, fever with chills intermittent, pain over the right side of the chest, which increases on deep inspiration and on lying to the right side, and also during coughing. And that time, that is on the year 2018, patient gets relieved on sitting and lying on left side. Now, at present, on patient examination, patient is conscious and oriented. Vitals are as follows. Temperature, patient is not having fever. That is, he is having normal temperature, and respiration rate is also normal. On examination, BP, blood pressure, that is 120/90. Pulse rate 68, and saturation is 84 in room air. On pain scale, patient is having mild to moderate pain. That is, I have already mentioned, patient is having right side pleural effusion, so he is having mild to moderate pain. On pain score, the patient is having total number of 4. Treatment and significant investigation. As I have already mentioned, that patient is admitted in hospital at present. As per doctor's prescription, all routine investigations done, which shows as follows. You can see over here. No need to explain, I guess. Now, psychological aspects. 70 years old married couple living with his 60 years old wife in a, that is Kacha house, and he had 2 siblings, but none of them helping him as they are already a citizen and not married yet. The patient had 2 siblings, but none of them are helping him. He was a farmer and was the breadwinner of his family. And at present, his wife is a manual laborer. Because of his illness, his wife has to handle all his household activities, and also hospital treatment also she has to do by herself. Now the source of income is from his wife's daily wages. At present, he is unable to go to the temple, market, and that makes him dependent to his wife. And sometimes he tells or thinks to his wife that his life is not worthy at all, and says to his wife like, I don't want to live, better to die, because of his illness. At present, the patient is getting injections of 2 gram because he's having infection. That's why 2 gram IV he is getting. Hydrocot, terifilin, nebulization, injection pantop, uh, then IV fluids also is getting. Because of shortness of breath, he's getting that Seriflow inhaler he is using, and oxygen also he is getting at hospital. Main concern, the we need to focus on patient. Before that, COPD is having since 2018. On top of that, recently he got diagnosed with pleural effusion pain because of pleural effusion. Because he is admitted at hospital, so financial problem will be also there, and shortness of breath, the main 4 points we need to concern about him. And summary: patient, 70 years old patient with COPD with a pleural effusion with dengue fever, is admitted at government hospital in male medicine ward. Discussion points: do we need to provide palliative care for this patient? What are the problems facing by this patient? What all can be done for this patient and his wife?
Thank you, Buddha Lohar, for the wonderful presentation. Anybody have any more clarification? Anybody need any clarification regarding this patient story? Please ask her. So otherwise, we can move on to the discussion points. Anybody? So, Buddha, I would like to know about pain medication. You have mentioned about this patient is having pain because of the pleural effusion. Did he taken any medication, any pain medication? How did you manage his pain?
No, ma'am, like he is having mild moderate, he is having pain, coffee. Okay.
Your
What?
voice is
Breaking.
breaking.
Yeah. Yeah. I have already mentioned that patient is having mild pain while coughing.
Okay.
Okay, for that purpose, as such, the patient is not getting any medication for pain, but because he is having mild, and in case of pain medication, in order to increase his,
Okay.
hello,
Yes, yes.
Uh,
Continue.
yeah, yeah,
yeah. See, you said the patient is having pleural effusion. Any tapping was done? Pleural
no,
tapping?
ma'am. Yes, patient is admitted before tapping. FNAC should be done, right? The patient FNAC has not been done yet. The doctor has been already escaped. Maybe today he had done, I guess. This history I took yesterday only, ma'am.
Mm, because you are saying the patient is having pleural effusion, and when the patient is coughing, the patient is
Yes,
having
ma'am. Yes,
pain,
ma'am.
right? Okay.
Yes, yes,
So
yes, ma'am.
whether it
Yes,
is
ma'am.
mild,
Yes, ma'am.
whether it is mild, moderate pain, I also cannot say. But I
Yes,
think that
ma'am.
because pleural effusion is one thing, it will really pain. It is a real
Yeah.
pain. Okay, so especially coughing. So maybe, as you said, today they must have done, and actually the patient needs a pleural effusion. Maybe the patient, if the effusion is more, then may need a pleural tapping, and the patient has to be put on medications. Otherwise the patient will fail. Maybe See, you told that patient told his wife that I don't want to live, I want to die. Okay, so a lot of things are there, na? Right? It's not only the pain, then family support is not there, only wife is looking after, wife is doing everything, no children, so he may be feeling bad also, why I am a burden to my family, and nobody is properly taking care of me, so many things, and that is all the problems the patient is facing. So yeah, we can also see no medication is being given for pain.
Yes, as ma'am said, no medication for pain. So the if pleural tapping is the only way to relieve his this kind of pain, because this pain is because of the pleural effusion. Okay,
Yes, ma'am. Yes, ma'am.
so yeah, so that should be done. And also one more question: do you have any specific question to ask us from this patient story? Do you want to
Yes, ma'am.
ask any specific question? Yeah, ask me.
Hmm.
Anybody
Yes, ma'am.
have any? Yeah,
Yes, ma'am.
yes.
Like, as I've already mentioned in discussion points, no, ma'am.
Mm.
Like, in our hospital, there is no like such group of palliative care in which we can provide palliative care to this patient. What can how we can help him? Like,
Okay. Anybody? I would like to hear from the participants. So she has one important question. She has already shared it with us. Do you have any suggestions? She don't have any palliative care department in her hospital, so she needs to help this patient. She is asking how can we help this patient. Any answers, please unmute yourself and talk. Anybody? Or you can put your answers in the chat box. Better to shift the patient or give health education? What kind of health educations you would like to give? Also counseling. Okay. Any other opinion? Advise him to take less water. Why? Okay, we can give psychological support and listen his problem. Okay.
We can provide psychological therapies to divert, or behavioral therapy, cognitive skills, and to divert a little bit with the counseling, which can support, I feel.
Okay, thank you. Any other points? We have total of 80 participants. So non-judgmental. Okay. We need to okay, holistic approach. Okay. He has already fluid in his stomach, so that she wants to ask the patient to uh, intake less. So here is the fluid is not in the stomach, in the pleural cavity. Pleural effusion. This patient is having pleural effusion. So, and also I don't think this patient is having any renal issue. Uh, Buddha, any renal problems this
No,
patient have?
ma'am. No,
No.
no renal
So
problem.
I don't think as fluid reduction is required, necessary. Means fluid level, maybe intake is less. No need to tell them, so they can take as much as they can. Ma'am, do you want to add anything? She is telling like advise the patient to take less water. So I
Uh,
don't.
why?
So she was saying like fluid in the stomach. I was saying like fluid is not in the stomach. The fluid is in the pleural cavity. So no need. And also this patient is not having any renal problems, but I think no need to restrict their fluid intake.
Yeah, yeah, very right. Yeah, no need of restriction of fluid, because, as you said, it's not abdomen ascites or something like that. It is
Yeah,
this one. No, it's a pleural effusion, and no renal problems. Patient can have fluids, and especially when, because the patient is having fever also, fever with chills, the patient will sweat, and the fluid intake will be less. If the fluid intake is less, the patient's fever also won't subside. Patient needs good, during fever, what we say, patient needs good fluid intake. So
yeah,
patient should be given good fluid intake, so don't
yes,
restrict that. But only thing is, during the cough, and also something has to be done for the cough, for relieving the pain, something has to be done. And hopefully, as you said, Buddha, I think maybe today they will do the pleural tapping,
pleural
or
tap.
whatever investigations they want to do, they will do, and then they can start off the patient with some medications,
Yes, ma'am.
right?
Yes, ma'am. Yes, ma'am.
Okay, okay.
So
Shiba, can I leave, Shiba?
yes, yes, ma'am. You can. Thank you very much for
Thank you all
the.
so much.
Thank you, thank you, ma'am.
Mhm.
You can play. So yeah. Buddha, I think so. Do one thing. I understand that you don't have any palliative care department there, but this patient need help, right?
Yes, ma'am.
So
Yes, ma'am.
yeah, so this patient is having pain. We can divide it into four aspects. He has some physical issues, social issues, as psychological issues, and spiritual issues also. So
Yes, ma'am.
for the physical part, we can hopefully the if we can able to done the pleural tapping, then we can able to relieve his pain. So this
Yes,
is
ma'am.
under the physical part. So I think that is the physical problem. So coming
Yes,
to
ma'am.
the psychosocial issues, do there are many problem. The no relatives are not willing to support. The wife is the only breadwinner of his family, so this will be affecting him a lot, because initially he was the breadwinner. Now he is having no role. He was not able to help to his wife, so that now he feel like I don't want to live, better to die.
Yes,
So this
ma'am.
is the psychological issues, and also spiritual issue also. If someone's like these kind of things, what you can do is you can listen why you are telling this kind of problems. What happened? Do you have any problem? Just sit down and listen. Try to explore his emotions.
Yes, ma'am.
Once he is able to explore his emotions, he feel like somebody is near to him to support him. That kind of feelings will be there. So we don't have any money to support, but at least we have a we can find out the time, at least half an
Yes.
hour, and sit near to the patient, next try to explore his emotion, and also his wife emotions also.
Yes, ma'am.
Wife is also is very tired, because she is the only person to take care of him, and also find out the money, that all things, no.
Yes,
So
ma'am.
if these problems, and also if he wants to attend wants to go to the temple, please arrange someone to help this family.
Yeah. Yes, ma'am.
Okay, at least one day he can able to go to the temple and do the things, and then come back, no. So that
Yes,
all
ma'am.
things we can arrange. And the next thing is you can find out the nearest palliative care centers. So
Mm-hmm.
better palliative care centers, and you can just give a suggestion. You can take palliative care or supportive treatment from there, and for the curative part, you can come here.
Yes, ma'am.
Along with the curative part, you can continue the palliative care. If there is a good palliative care center there, you can connect with them also,
Yes,
so
ma'am.
that they will get a supportive treatment.
Yes, ma'am.
Okay.
Yes, ma'am. Thank
Uh,
you.
okay. Any other points? Anybody want to add, or any suggestions? Anything? So I think is clear, right? Buddha is clear.
Yes, ma'am.
Any other
Thank you.
questions you want to ask?
No, ma'am.
No. Okay. So if you don't have any questions, we can wind up the session.
Thank you,
Thank
ma'am.
you.
Thank you, Shiva Sister ma'am.
Madam, I have a doubt.
Yes.
I have a doubt regarding this assignments.
Yes.
So completion of 2 classes, as you said that the assignment can be started. Is there any performer
Yes.
like say from Pallium India is there for writing the assignment, or we can just start with the Microsoft?
Just you can log in that link and just open the link and see how can we if you need any help, or try one thing, do one time, and uh, before attending the one small request, before attending the assignment, you have to go through the learning points and at least an audio things, so that you will get an idea. It's not a hard thing, it's easy questions only. The thing is, please read well, and that there are 4 multiple the answers there. The 4 answers there. It is a multiple choice questions. 4 answers will be there. No, so you have to choose on answer. No, so that if you read well, go through your that study material, definitely you can able to answer.
Now this is regarding the assignment. Assignment you are talking about.
Yes. This is regarding the assignment. This is regarding the assignment.
Okay. Thank you so much.
Thank you so much.
Okay, thank you, Shiba ma'am, for facilitating the session wonderfully. And thank our faculty has left, but thank you for taking the sessions wonderfully. Thank you all for participating in session. Thank you, everyone. Let's see in the next sessions. If you have any doubts or queries regarding the assignments, kindly give posted in the group. I will reply accordingly.
Thank you.
Hello. I have
Yes.
just a moment. I have one doubt. I have sent to the case presentation. So in the WhatsApp only. So is that any other way I have to send it, or?
No, so WhatsApp is fine. I will check it with the facilitator and will let you know if anything.
Okay, yesterday night, around 7 above I have sent in the evening.
Yeah, I saw that. It's fine.
Oh, thank you.
Thank you. Bye-bye. Take care.